Good morning, everyone, and welcome to our second session on our QC webinar series. We apologize for the glitches while starting up. So we received quite good feedback during our first webinar, and we saw it fit to hold a consecutive webinar where we are going to also expound and elaborate in detail on what Madam Jackie presented in our first webinar on introduction and also reinforcement of important QC practices, and expound comprehensively on QC and key management concepts. So our speaker today, Madam Jackie Agunda, she's a quality lead at Aga Khan University Hospital with accreditations achieved from CAP, SANAS, and the JCIA. Trainings and competencies from the BSc Chemo, Masters in Medical Laboratories Sciences from JQuat, and also when it comes to leadership and management in health systems from the University of Washington. So welcome, Madam Jackie, and we look forward to having a very fruitful session. So just quick housekeeping rules. Please keep your mics on mute. And in case of any questions, please engage us in the chat section. Good morning and welcome.
Yeah, thank you so much. And I have a pleasure this, is it afternoon already? No, it's morning, to present to you whatever we will do. And feel free, I know quality is wide, but you may have questions relating to what I have not presented. Please preserve them, keep them under question and answer. I know Leah and the team, they'll be giving me to maybe air them out or iron them, just to see that we work together. As I've been introduced, thank you so much for introducing me in a very nice way like that. And I believe in the teams that we are talking to. We have different cadres. We have doctors, we have technologists, and we have all manner of personnel under this. So I'll try to go deeper than what I did last time, because last time it was just an overview. And our objectives, as I have shared there, are as listed. We'll be able to discuss quality control practices. We will also ensure that we explore the patient safety, explore the management concepts, at least just in summary, because when we talk about quality, you may have a whole semester just discussing quality, because I remember in our master's class, we did a whole semester of quality management system. So in terms of introduction, when you hear the word precision, precise, I'll be defining it down there. Precision, people will tell you it's reproducibility. If you're able to give results that if you test the same sample today and the same sample, you repeat it on the same equipment, it should give you results that are close to each other, to like not so much apart. You are trying to be precise. Your results should be reliable, because if you don't, then it means we live in a society where you want really to know if you have HIV. Sorry, I'm using a very tough word. If you have HIV, then you need to be told, I have HIV. You don't need to be told, I have HIV and you don't have HIV, or you don't have and you have. Another example can be sugars. If your sugar level is high, you need to be told your sugar level is at this and not the other way around. And that is the diagnostic purpose of laboratories. Previously, we discussed about pre-analytics. And when you talk about laboratory quality assurance cycle, we talk about the whole cycle of pre-analytics, analytics, and post-analytics. When you talk about that, pre-analytic is before the specimen is analyzed. Specimen, you can call it sample, before it's analyzed. That is before it is tested. When we talk about analytic, we mean when the specimen now is being analyzed or tested to give you the results. When you talk about post-analytic is when after now it is tested, then you're looking at some of the things that happen there. In all these things, in that cycle, you may have errors, and possible errors will make us not give the patient what they need. So when we receive the errors, remember this is a safety issue to the patient. If we have made an error in pre-analytics, or we have made an error in analytics, we have done an error in post-analytics, all this may lead to us not giving the patient the right thing. I have highlighted some of the errors that may occur. Don't say we didn't pull all of them there, because you'll get some that are different from what I've listed. I've just given an example. Patient identification is something that is very key. I'm not saying that Aga Khan, we don't struggle with that. Patient identification is very important. And no wonder we have even invested in technology to just ensure that we identify our patients correctly. When you don't identify the patient correctly, I'll give you an example. If you get a specimen from a patient, and this specimen, let's say, belongs to Jackie, and you have gotten a specimen, let's say you have written the name of Leah. Leah, forgive me for using your name. So you have identified that specimen as Leah, but in real sense, you got the specimen from Jackie. So what happens is, for example, you have the request that you're dealing with is a cross-match or transfusion. What you're likely to do is, you are likely to identify Jackie as A negative, A positive, and in ideal situation, Leah is B positive. So if it comes to the section or it comes to the lab, most likely you'll give Jackie damu yenye si ya Jackie, but cross-match will go through in a very smooth way because the blood that was there was cross-matched nicely. It was done blood group nicely, but in the event, you're also going to do a fatal error. So if you give an A to a B person, like seriously, you've killed that patient. That is how serious it is. Previously, I said your specimen integrity is equal to the quality of results that you're giving. You may come up with container which is wrong. If you don't have the right container, you will not give the right results. For instance, if you have to do a CBC, you need an anticoagulant that is strictly for that specific test. How you store it, the test that you want to keep the specimen at may be called temperatures. You really need to ensure that those temperatures are strictly followed. So pre-analytics is very important. Some of the errors that happen under analytic, I have mentioned there. When you're analyzing the specimen, you will look at maybe the equipment, is it being maintained? If it's not maintained, then it will not give you results of integrity. If the staff is not competent enough to analyze that specimen, they may not know the procedures. They may not, yes, all those, they may give you wrong results. When you come in terms of post-analytic is where we have done the results, the tests are okay, they are all done well, the equipments were well done, but now we give results again to wrong patient. And in this, we'll also talk about patient misidentification. So what happens is all these steps, all these items, they will consist of the cycle that we call quality assurance cycle. You must look at all of them when you're doing your quality assurance. So I have mentioned them up there. I was just trying to tabulate them down there. And so for your info. Internal quality control. What is internal quality control? Because basically today, this is basically what we'll be discussing and anything that is around quality control. I have done a small definition there, use of control samples and statistical methods that contain analytes in concentrations close to the medical decision limits. When we talk about medical decision limits, we are not talking a big jargon. What we are just saying in simple terms is that when a patient is high, a level is high for an analyte, let's say it's potassium. When we have potassiums as high as, let's say, 7, potassium or 6, potassium of 8, the QC that we use is close to that. So when you're choosing your QCs, you need to ensure that it captures at least close to values that are close to medical decision limits. And when it's lower, you also want to get a QC that is actually taking care of your lower limits of detection. So I have said there that control QC material can be lyophilized, that is powdered. It can be liquid, that can also be liquid. You don't need to reconstitute. For lyophilized, you'll have to reconstitute. For it to be liquid, then you analyze. One point that I said before, and I have repeated today, when your QC has failed and you have not done any troubleshooting, you have not made sure that it passes before you run patient samples, please do not give the patient results. We also know that when we are also looking for these QC materials, we want to ensure that they mimic the patient samples. For instance, you cannot be running a QC for, let's say, body fluid, and you're using blood samples, whole blood. That does not work because you want to mimic what the specimen is, and you run a QC that is, because all factors have to be constant. So in continuation, we want to say we have qualitative and we also have quantitative QCs. And you know what qualitative is? You will say things like it's positive, it's negative, it's present, it's absent. That is the language of qualitative. So as per manufacturer recommendation, you'll report as the manufacturer has said. So when you choose controls again, you also need to look at the cutoff of the weak reactions. For instance, when you're doing HIV, I don't know why I'm using HIV so much today, but I think it's because when you do all these audits, you find some things that stand out. HIV has cutoff when you're doing reporting. You cannot have a QC, maybe your cutoff is 0.1 and your QC is way out of there. So you'll not be reporting these things in an appropriate way. So when you're doing choosing what to do, also look at the cutoff of the weak ones, because if you have your negative at a cutoff of 0. Let's say 0.1, you want to get a QC that is close also to that. So that, because again, previously, as I have mentioned, you want to get the medical decision on the same. When you have agglutinations, this one I can only think of TPHA, Treponema pallidum hemagglutination test. That is an agglutination test. You want to include your weak positive in your controls. When you have that tile and you're doing a testing, you want to compare what is weak so that you don't miss out on weak positives. When you have tests that have extractions, you also want to get QC for the extractions, and that is about our qualitative testing. Some of the types I have told you, we have under qualitative, we have those that will describe, then we have those that will tell you positive, negative. We'll tell you that we have those that will tell you reactive, non-reactive. We'll tell you this is normal, abnormal. Yeah, so all those are ways of describing your qualitative. So microbiology is a bit different for people who are here and they're doing microbiology. When you are doing QC, first of all, you need to make sure that your media is enabling growth of your bacteria. For instance, imagine you get media that is so sterile. You put or you swab or you do whatever you do, then you find this media is not able to support growth. You'll have done zero work. So quality control in microbiology is a bit different. We need to look for organisms that are predictable, and their reactions will verify that these strains are there. Some of the examples is ATCC, those ones you know, those people who are doing microbiology, and they are bought. You buy and you come, and then they are liquefied, and then you will culture and see if your control passes. So if you don't have those buying ones, some people will just get strains that they have identified and they know this is streptococcus, and they'll keep that strain for use in future, and they'll use that as QC. Some people will use EQA material, that is proficiency, to do that as their EQA. Semi-quantitative, I talked about TPHA. They're actually similar to qualitative. It's only that after you have reported, you have an estimated figure. I've given an example there by saying 2 plus, 3 plus, and when you that I can only think of TPHA. I'll also think of is it VDRL? No, that one you'll also quantify. Once it's positive, you need to quantify. How is the reaction? You're just trying to tell the doctor, as much as this is positive, it looks like close to the concentration is high, the concentration is low. So that is why we say 2 plus, 1 plus, 3 plus, they need to know the concentration of the infection. In terms of quantitative QC, this one is where we are using numerics, numbers. Numbers come in here and we measure the quantity of the analyte that is inside that sample. And after we have done the measurement, we must make sure that it's accurate and precise. When I talk in terms of accurate, we compare to the standard. What you have used to compare is comparable. What is precise is what can be reproducible. If I do the same test right now and I run it the same time, all factors constant, should give me results that are close to each other. That is what we call precise. When you're doing your IQC and you find they have failed, make sure that you do troubleshooting. It may just be a small error that has occurred. And once the error occurs, you do the troubleshooting. You want to see what is the cause of my QC failure. So what you do, you look at your reagents. If you have changed your lot, maybe that QC is in a different lot, so your ranges are different. You want also to check at the maintenance, if this equipment needed calibration, if this equipment needed PPM, is it done? PPM means preventive, planned preventive maintenance. Did you allow the QC, like I said, we have lyophilized, then we have the liquid ones. There are those that you'll freeze. There are those that you'll put in the fridge. Did you allow it to settle? Most of the manufacturers will tell you, keep it at 15 minutes before you analyze. Did you allow it to settle? Did you allow it to thaw? Did you allow it to, once you mixed the lyophilized with the liquid, did you allow it to settle? Did you allow it to mix properly? So did you follow the procedure of that IQC when you are analyzing it? Another thing to look at is now, as I had told you about the competency of this staff. Maybe the person who is running it has changed. Is this person competent enough? When you're doing dilution of the lyophilized material, have you calibrated your pipettes? And by calibration, I want to encourage us that given that we have gone through a lot of accreditation, I want to tell you that again, after the pipettes are calibrated, there is a way you need to verify that the calibration is okay. What you do is you come in and do some measurements. You ensure that whatever this pipette is picking, if it's a 10, if it's a 20, if it's 100, if it's 200 or 1,000, whatever it picks, it's actually the whatever it should pick. Very important, because you'll be giving, let's say the manufacturer has said this lyophilized I need to dilute with 1,000, and I have given 900 or even 800. Believe me, there will be a problem with the IQC. Why have I picked on equipment validation and verification when we are talking about IQC? It is very important that you note that equipment that we are dealing with will give you wrong IQC, or they'll give you QC that is not verifiable because they have not gone through the proper verification process. When I talk in terms of validation, validation is where the manufacturer has done that for you. They have validated the test. When it comes to us, you have to verify your equipment, what the manufacturer has claimed that it's working. So you verify that it's actually okay or correct. So accuracy and precision of the equipment is really very correct. Why I put there POC is because I wanted to mention something about point of care testing. This actually includes when you're using point of care testing equipment. I want us to know that in ISO 15189-2022, they have included point of care testing, and it's part of the scope that people are now applying for accreditation. As you do your laboratory equipments, also remember that the equipments under point of care testing also should lie under laboratory. So as you look at them, as you do whatever you do, make sure that whatever applies this side also applies there. The logistics of point of care testing is a bit different, but it doesn't mean that those equipments should not be validated or verified. So you must ensure that they are also verified and good to work in the clinical space that is near the patient. Why should you do a validation? You want to do that validation or verification. I want to be using the word verification because verification is what we are confirming that the manufacturer has said that this equipment is accurate by this. This equipment is precise by this CV. We are trying to verify what the manufacturer has said. So we want to ensure that it's accurate, the results are accurate and impacting on all the clinical decisions that the doctor will have to do, or the clinician. Regulatory compliance, I mean, when you are accredited, let's say in Kenya, we have our local regulatory bodies. You want to comply with what you're accredited for. So I have said there are some of the accreditation bodies, international, not local, maybe FDA, that is Food, Drug, and of Abuse, and then ISO, which is ISO 15189 for laboratories specifically, and then CLIA. What we have currently at Aga Khan is ISO and CLIA, because CAP has borrowed some ISO 15189 standards, and they are also having CLIA. So we also want to ensure that results that may lead to misdiagnosis, they are not there, and anything that will lead to improper treatment. For example, if I have not validated my equipment, if I have not verified my equipment, and then I come, iko tu pale, it's just there for those who understand Swahili. It is just there. And then I decide to run, let's say, troponin. And I give a troponin a result of a patient that is within normal. In an ideal situation, this patient is having a very high skyrocketed troponin. What am I saying? This patient is going to get a cardiac arrest. The patient will not be given treatment because the doctor cannot make a decision knowing that this patient has a high troponin. We have told the doctor this patient is normal. In fact, they'll be confused. So they may not proceed to give medication for cardiac arrest. Another thing for reputation. Remember, I told you we live in a space where lab nowadays, you will have to meet a lot of people who are so aware of what their rights are. So you'll meet a lot of litigations, and then clinicians are like, this lab is not credible. So yes, that is why we should validate our equipment, ensure that it's working properly. And when we talk about verification, we want to do installation qualification, we want to do operational qualification, we want to do performance qualification. What do we mean? When you're installing, you want to verify that this equipment is installed correctly and ready for operation. Once you do the operation qualification, you want to know, ensure that this equipment operates within the predefined operational ranges. For instance, if I have installed this equipment and I have done my verification, and the manufacturer has said that my precision needs to lie between this range, I have to ensure that that is exactly what it is. Again, I want us to know that once we do these verifications, remember, most of these equipments are not prepared in Africa. They are prepared in Europe or anywhere else. So they'll come here. So we will have to ensure that as we are in Africa with our temperatures, remember some of them are snow. As it comes here, we need to verify that in Africa it is working correctly. As we do our verification, as we do our reference ranges, we want to ensure that this population of Africa, our reference ranges are this. But this equipment under these temperatures, it's working appropriately. Let me incite some of you and know that once an equipment comes, the manufacturer has stated under which conditions it should stay. For instance, if it says that we are supposed to keep this equipment, let's say a hematology analyzer, it is supposed to be kept at temperatures between 15 and 20. And maybe you live in Wajir, where temperature is never in that range. So what you should do is you make sure that you have either put a fan that will be cooling that temperature, that it works in those temperatures that are predetermined by the manufacturer. I hope everyone has understood that. So we also want to check the consistency once it is installed, once we have confirmed that it's operational and is performing well, we want to ensure that there is consistency. Once it is continuing to work every time we are monitoring, IQC comes in there. IQC, EQA, and all the rest. So I was just trying to tell you some of those words that we use when you're doing that validation, and accuracy is one of them. So I have told you in simple terms, if someone asks you that what is accuracy, just tell this person, accuracy is being accurate, but you don't use the same word to define the same word. So accuracy means you're comparing to the standard. For instance, if you have been using an equipment that you have been verifying all consistently, that equipment becomes your standard. The one that is coming in new will be your test. So you're comparing the two, standard versus the test. In terms of precision, I've mentioned severally, and I have said what it means. It may be reproducibility. Some people will call it repeatability once you run, and it is actually comparable by percentage CV. Some people will compare by standard deviation as maybe the quantitative measures of dispersion. So I have put their sensitivity, specificity with an intention. Some equipments will need to do specificity if it is an equipment that is doing qualitative analysis. And also do specificity if it's an equipment that is doing qualitative analysis. Most of the time, and most standards will tell you that you verify your sensitivity as claimed by the manufacturer and the specificity. So very many different people will define it differently, but just know that sensitivity, you're just trying to check how positive true positives are, specificity how true negatives are. Basically, that is what it is. You don't need to really cram the definitions because you're not setting any exam today. But once you know what it deals with, you need to verify what the manufacturer has claimed, that this is the sensitivity, it's 100%. Most of them will tell you it's 100%, but verify it. Specificity, the same. There is a lot of technology around, and some people will even give you tools to do that sensitivity, to do the specificity, and you'll come up to their figures without being tired. So please explore even more of that. Measurement uncertainty is a whole topic that people need to learn the whole day. The whole day trying to understand what measurement uncertainty is. But just understand the way I have put there. It's a value like in which the true value is reasonably expected to lie. From what you have, what is the likelihood that this will lie, will not be true? Yeah, from the data that you have. And as I've used the word 95% confidence, what we do, you may use your reference ranges to do a measurement uncertainty. You can also use IQC data, for example, data that you have used for a whole month. You have done IQC for a whole month, you have your CV, you have your lower limit, all that. And as I have said, we can sit here for the whole day just trying to do measurement uncertainty. The requirement is, as per accreditation standards now for those who are accredited, that you do at least when you're doing your verification, the initial verification. And it's also required when the equipment is like, there's a major preventive maintenance that has been done that has affected maybe operation of that instrument, then you can do another uncertainty of measurement. But once you have done it, you can basically stay at that. Again, just to continue, I've mentioned this before. So you need to know that the staff who are doing your IQC need to be competent. So when you're doing your competencies is just making sure that a staff, first of all, is trained. And then after the staff is trained, you ensure that they are competent enough by doing some exam, small exam, not necessarily, don't give people pressure because no one likes doing exam. So you test them to see how competent they are. So you check if calibration is acceptable. For people who are in chemistry, you know that you'll see analytes which need calibration consistently. You also check your reagents. Are they okay? Something like that. So in terms of, again, as we continue with quality control, is a crucial component. I want you to know that once you ensure the issue of accuracy, precision, we are trying, when you run your IQC, you're actually trying to ensure whatever you did as a validation or verification before, you are trying to continuously verify that it's there. That is why when I even mentioned in terms of long-term precision, I have not mentioned, let me mention it right now. In terms of your long-term precision, once you do your IQC, you will check your monthly QC, you'll check that data, and you look at the CV that is coming out. You'll know if this equipment is precise, okay? That will really help you. That is why I have said there, it will help you in checking your precision, it will help you to check your accuracy, it will help you to check your reliability of your results. We are not talking about just monthly. Every day as you do your QC, you'll ensure that it's passing. And as it's passing, how is it? So review daily is very important. Review monthly is also very important. But as you review continuously, because that is when you will know whether there's a bias, there's a what, something like that. What are some of the control samples that we use? Why I have put that there is because some people may be struggling. You really want to buy QC material, but you're not able to buy. I'm not saying don't buy. Please buy QC material. But in the event, Biorad has not supplied, don't kill yourself. Don't bite yourself. Don't say we are not able to analyze samples because we don't have QC. There is something called alternative testing. So what you do, you get the previous sample from the patient, but something that you need to ensure is before this specimen was analyzed, the QC was existent. So you analyzed it when the QC was there. Analyze the sample and then check the comparability. What we use and what we recommend is use total allowable error. All this you can get in the website under Westgard rules. You can also use data innovations. So compare the two QCs. Let's say you have picked 3 specimens. You want to compare low, normal, and pathological high. So all the two, like you're comparing previous QC, this sample for today, sample for tomorrow. You'll put a table, you'll compare the difference in those results, you'll calculate your percentage difference, and then that will be compared with total allowable error. You'll have your QC in place. But before you do that, please make sure that you have a policy on the same of alternative testing. It will really help you because we are human beings, and these companies, including Biorad, they may have issues at the airport, issues of clearance, issues of all that. and then you are not able to test. We are not saying consistently do alternative, but what we are saying, in the event you don't have anything, then you can do alternative testing. In terms of calibration, ensure that your instruments are regularly, by the way, maintained, but you need to also verify. Your calibration verification, we are lucky that it's done by our EQA provider. So a calibration needs to be done and ensure that it has passed. So if an instrument, the manufacturer has said that you calibrate your instrument, please ensure that it has been calibrated. And if you're using the graph of calibration to determine your results, please make sure that it's not deteriorated. You need to change it regularly, because if it says your calibration needs to be done within this time, ensure that is what is happening, because you are likely not to interpret, or this instrument will be confused on how to interpret your results if it's based on the calibrator. So you need to do regular monitoring. Recording and analyzing your data, you need to do it oftenly, as I have mentioned, that daily has to happen. You don't need to to wait until you have analyzed a QC, you went away or went to take tea, then you put your results there, your samples to run, then you come, then you forget. Did I even look at this IQC? It may not have failed, by the way. Sometimes it may not have failed, but from how it is behaving, already there's a problem. And we'll capture something down there about our trends, our shifts, and all the Westgard rules, how they behave and how you should look at them. So sources of it, you can get from commercial. I have explained how you can get yourself an in-house QC. Just something to remember. Before you pick that sample as your alternative QC, ensure QC existed and you analyze that sample with quality control that you are using. I have mentioned about those levels of QC, qualitative, quantitative, and quantitative and semi-quantitative, qualitative. So when we continue with quantitative IQC, why I have put mean there? Because there are labs, and even how to calculate. There are labs which struggle. I'm not saying that everyone is blessed different, same way. We are blessed differently. There are labs which are struggling. At least even that lab in upcountry or wherever you are, try to just make sure that at least you know what is your mean, what is your standard deviation. When I say this is the symbol for mean, this is the first, second, third, fourth. I have told you about getting your QC in a month. For instance, you've been analyzing, so you want to know what is the mean of this QC that you have been analyzing. Just get all those parameters. Nowadays, we are full of technology. Put those parameters in a calculator in the system, and then it will calculate for you what is your mean. If you're not able to, get a calculator, get the first parameter, get the second, the third, and the last, up to the last. Then if you have 20 of them, your N will be your number 20. Then you divide. Get the total of this, then divide by that, you'll get your mean. Basically, that's how you do it, and it's as simple as that. When you're looking at your data, now you have done your QC, you want to see what is your CV. Now we have come to precision, my friends. When you're doing your CV, and we are talking in terms of CV percentage, sorry, I forgot to put here percentage. We will use this CV percentage to calculate your precision. And the manufacturer has told you from this data, you're expected to get a CV that is ranging from this to this. This is the formula. Get your standard deviation, divide by your mean that is up there. I don't know if I put some standard deviation formula. No, I didn't put. So if you do your standard deviation and you get your mean, you're able to get your CV, then you multiply by 100% to get your percentage CV. If you're struggling calculating standard deviation with those formulas of statistics that we are being taught in college, please don't. Nowadays, it's easy. Just put your data there and say standard deviation calculator, and it will calculate for you and give you a value. And then come up with what you have, put it in place. You don't need to, sometimes if you're not accredited, to not do these things. Just do them as simple as you can. You never know. Maybe this is an appraisal tool for you, that you came up with something that people have not been using in your place of work. So again, CV is what we say coefficient of variation. We'll use coefficient of variation or standard deviation to express our percentage. And we will also check if we are precise. What are we, if we talk in terms of standard deviation, or how are you deviating? How are you deviating from your mean? In case your mean, for example, in this place, if your mean, I don't know if you guys can see this. If let's say your mean is 4.1, how are you deviating from your mean? And once you get your standard deviation, you'll have your standard deviation 1S, you'll have your 2S like that, What you do to get this other value on top here, you add your standard deviation on your mean, you'll get your plus this figure. It will be your one standard deviation. Then if you add again, you'll get your 2-1, this one. Like that, up to 3. What I'm trying to show you is how to get your LJs. This is something that is not hard. Don't feel like it is something rocket science. After you have done that, you're able to even use a graph table to just do your Levy Jennings and see how they're dancing, how they're flowing on those on the graph. You will check if you have a trend, if you have a shift, something like that. I have mentioned that do not report your results if your QC has failed. What is a trend? A trend, I have just diagrammatically showed you. There is something that is flowing from same direction. Your drain, your QC, it is flowing. Like this is a very systematic problem. There is something that is happening. And remember, I told us that immediately you run your QC, don't go for T, then put your samples, then they are running, then you come after the results are out, then you forget even to look at your QC. So remember now, this is a trend. You ran here, it was like at the mean. You ran the other one, it went to your 1S. You ran another one, it's there. You ran another one, is there. What should happen is your ideal QC that is nice, it should dance. It should dance with the mean. Just look at my cursor, how I'm doing it. It should dance like that. And it should not like violate very many rules here. Like when you're running out of your 1S, you're going to your 2S, already you're getting a warning. You're running there, you get to your 3S. That is a stop, my friend. So you have to check your trend. It is trending from one direction. When you talk in terms of shift, and very many people will confuse the same, I have labeled here and say your shift has just occurred here and it has shifted. Yeah, the first instance where it changed, that is what we call a shift. But when you talk in terms of a trend, it has gone from one direction. Someone would ask, what is the difference between the first and second graph? If you want to define it as a trend in the second graph, you have to draw this thing coming this side. So a shift can only be where it twitched, like it changed. What are some of the errors that we get in IQC? When we define errors, you'll first categorize them into two. First error, we can be random. Then the next error, it can be systematic error. Because random may just mean you are running let me go back here. For instance, you came here, it was dancing, then it just shifted, then came back to the normal. That is random. But when we talk about systematic may mean consistency. It has been happening. We even expected. Imagine looking at such a graph. We even expected there will be a problem. You see, it is up, up, up. This one, it is going up, up, up. So by the time you are reaching at your 3S, this is already a problem. And you knew it. So if you didn't review it, you knew this problem was coming. And that is where we call systematic. It's already predictable. There's a deviation that is predictable. You can even tell that is a systematic problem. What are some of the examples of Westgard rules? I have tried to simplify it. When I was still in college, when people were speaking this language, I used to see like it's jargon and I could not really get it. So one day I dreamed that I'll have to simplify for people to understand. I've just tried to put graphs on for you to see what normally happens when someone tells you this is a 3-1-S. And chemistry people here will tell me they deal a lot with Westgard rules. Hematology may not be so much of culprits because again, most of their instruments they'll use maybe 1 or 2 rules, but they'll not use all of them. Chemistry, most likely they use most of them. So when someone tells you you have violated 3-1-S, what does this mean? That there are 3 consecutive results, 3 results consistently, 1, 2, 3, that they are greater than 1S. And when you look at this graph here, 1S is here, 1 is here, 2 is here, 3 is here. So if they violate 1S 3 consecutive times, 1S around here, it will be 3-1-S. I forgot to put at least a graph for 3-1-S. Sorry for that. So when someone tells you, we have violated 4-1-S, what we mean is 4 consecutive results, 4 of them, 1, 2, 3, 4. They are actually greater than 1S on the same side of the mean. If it jumped this side, it is not 4-1-S. I hope you guys understand what I have said, like the graph that we have represented here. So 10 X, we mean 10 control results and on the same side of the mean. Remember the difference between the 10S and all those others. Imeenda sana, it has gone. Remember some of these rules, once it goes beyond even 6, that's a problem. And you may be looking at a systematic problem, and this systematic problem may be anything. It can be control load that you're using. It can be the equipment that you're using. It's having issues, you're not paying attention. So by the time you reach here, let's say this is 1, 2, 3. By the time you reach here, it is not coming up. It has to pass the bit. It's not coming up. Start looking, start checking what is the problem, what is happening here. By the time it's reaching 10, that's a problem. You need to look at what exactly you're dealing with. There is a trend, and because now here it's at the lower side of the mean, most of the time your results that are on the lower, this part, they'll just be reading this side. That is what it means. If it comes, it's just on the upper side of the mean, that is exactly what it means. All results that are supposed to be dancing or giving you the right results, they'll just flow around this side. I hope I have made myself clear. External quality control. There's a difference between internal and external, as I mentioned before. Some people will tell you when you're doing qualitative, when you're doing a test and getting IQC done, that is external quality control. No. What it means is you have tried to compare yourself to external people from your lab. So some people will call it proficiency testing, and some people will use alternative testing. What do I mean by proficiency, and what does it even entail? I have put this graph just to guide us and help us. Laboratories will actually, you'll get an agency. For instance, Aga Khan will use CAP, or you'll use UK NECAS, or you'll use any other vendor. And that agency will actually come up, they have a program. You will enroll because you pay for it. You don't just go and say, me, I want to be part of you people. You pay. After you pay, they'll give you material. After the material is analyzed, you will send back the results to them. And then they'll compare these results from the peer. For instance, it's Aga Khan, it's a Nairobi hospital, it is UK, it's US. And then they'll compare how you have performed. They'll compare you to the peers, and then they'll give you results as per how you have performed. One thing you need to know is that once you have submitted, for instance, a report for urine chemistry, I'm just giving an example. You have reported urine chemistry that you did on an equipment. You will be compared specifically by the peers that have analyzed that urine chemistry on that equipment. For instance, people who have done with Biorad will be compared with people who have done with Biorad. So they don't mix. So if you have done with another one, they'll compare you with another one. That is the whole essence of proficiency testing. When you're doing alternative testing, as I've mentioned in IQC, even EQA, they have alternative assessment. In the event you don't get a vendor or an agency that can give you EQA material so that you can do, you are allowed to do alternative assessments. Some of these alternative assessments are interlab. An interlab we will send to, let's say, a sister institution. They analyze, we analyze, then we get expert opinion who will look at the results and mark. Ni kama kufanya exam. You're doing an exam and you are marked on how you have performed. For instance, I'll give you an example. In our EQA program, we don't have a program for malaria testing. So what we have done an interlab. So what we do, we get the labs to submit those results to one of our pathologists who is a very well-trained and proficient in malaria testing. So we use that pathologist as an expert. So that pathologist is the one who will mark our exam and give us our results. There are very many other alternatives apart from interlab. On a bare minimum, you can also do split testing. If you completely cannot, and I don't think you can completely not get a lab to compare yourself with. If completely you cannot get a lab to compare yourself with, then you can do split testing. And by split testing, I mean you just split your tests among the technologies and you see how their performance is. And then you keep that as your EQA, external quality control proficiency testing. So plus many more. So yes, let's proceed. Again, if the results are unacceptable, then you have to investigate. The records that you have, you must keep them, because if you have accreditation bodies, they'll come looking for these documents and they'll review. Again, when you receive your results from the agency, from the vendor who has given you the provider of the proficiency testing, you need to review them. And you also, if there is any failure, if there's any failure in your proficiency testing, remember just the same way we're investigating IQC failures and troubleshooting, the same way you should investigate and troubleshoot your EQA failures. Remember we said you should analyze your proficiency material the same way you analyze your patient testing. So if you find they are unacceptable, make sure that you investigate, you'll write the root cause and just do a preventive action. In the event that you have failed, you want to know, why did I fail? In the event for the whole year you have been having a bias, why am I having a bias? It's the same way we are looking at our IQC. What are we saying? When we do all that, make sure that you are also integrating EQA proficiency in your patient results. When we have failed in our EQA, we want also to look at how is the performance of our patient. For instance, by the time you analyzed your EQA, how was my IQC? Was it having a bias? Was it the cause of why I failed? If we failed in our IQC, we failed in our EQA, how are our patients? So if you look at all that, you also need to look at your patient testing at that point. Did we report patient testing with this failed IQC, EQA? So you review all that. Someone will ask me, will you try calling patient to come back so that you try to investigate? Yes and no. You may, depending on the root cause that you have found. If it calls for you calling a patient and even repeating that test, then be it. Please call the patient, repeat the test. Someone will ask me, at whose cost? Please, those are operational problems. You deal with them if you're an institution, and because leadership should always support quality, they should be able to back you up. How do we integrate QC with our management concepts? Someone is raising their hand. I think Leah and Tim will manage that. So we should encourage collaboration among staff, because why we say that? QC, if you're like appointed QC manager, like what I do, I'm quality advisor, that is the quality manager. What you do, you ensure that it's not a one-man show. It is for all people to do this. So ensure that all teams are improving their QC practices. It is a data-driven. Don't start telling people they have done this, they have done, and you don't have evidence. You don't have even data to support some of your processes. So ensure that you have your QC. If there is a bias, you are seeing your bias is here. Let's sit, let's discuss. Have meetings. Talk to them. Let people understand. You don't tell people things that they don't understand. First, train them on what we are talking about so that they understand you're on the same page. Have meetings, have feedback. When I talk in terms of culture of safety, that is self-reporting. When you put that quality system around and people understand so well, and it's not punitive. When you're introducing, it's also a problem. But once they're used to it, it becomes something a norm. So allow people to self-report themselves, and don't be punitive. Don't make them feel like they are on the wrong. They'll be fired tomorrow. Don't. So if they know, they feel their jobs are threatened, they'll always hide things under the carpet. So culture of safety, we mean people are coming to self-report themselves. They'll tell you, this report I reported wrong. Imagine QC, I don't know what happened, but I think I did a wrong QC. And when you are feeling those CAPAs, corrective action and preventive action CAPAs, you ensure that you are really objective. Train them. Look at the performance improvement. What has helped us to grow is that, and I want to give you a leakage. I hope what has helped us to grow is that even in the performance appraisals, put quality management in it so that when you give people either maybe KPIs, it may be quality system essentials that they'll be dealing with at their level, let that also be included in their appraisal. As I work hard in my quality, let that reflect also on my payslip. That has really helped. And so people will be proud. Like, I did this. This was my project. Don't water them down. They have worked hard for it. So please give credit to where it deserves. So clients should also be encouraged to give feedback. When a patient complains, don't say this patient is very, they are fussy. Patients can be fussy, but yes, once they give feedback, look at it objectively. They may be giving you a point that may make you really improve. Do satisfaction surveys. If you can give patients some forms to fill, let them comment freely about you. You can use a system. As we have a system, they'll send a message to the patient just to allow them to comment on us, talk about us. It may be very negative. Of course, human beings will always talk about negative things. When it comes to positive, very few will give you positive feedback, but it's okay. That is the only way you can improve. You cannot be talking about quality QC when you do not have good reagents. And that's why I've put reagent inventory in the same, at least one slide there. Manage your reagents. You're not able to do IQC because you don't have QC. So manage your stocks, do projections, make sure that you're okay. Verify adequate amounts, and IQC, when it comes, also verify that the values you're getting, they're actually supposed to be the correct values. Because IQC will come, and let's say maybe Biorad has supplied you with IQC material, and let's say, for instance, maybe where they were keeping them, they were not keeping them at the right temperatures. I'm just giving you an example. Please verify that your IQCs are working correctly. How to do that is you do lot to lot, or QC verification, you may call it whatever word. There is always a formula to do the same. So compare, as I told you, when you're doing alternative, you can use verify this with that, even if you don't have a tool. Verify, use your total allowable error just to compare if these QCs have passed or not. it's not a must you have automation. But if you can afford automation, it is the best way to go because it isn't your work. But if you don't have automation, don't beat yourself. Please use logs. Just document those QCs on your log. Also establish your reorder points. For instance, maybe you know that this QC will take me 2 weeks. Please ensure that you have a reorder level. At what point are you getting the other QC? Because at some point you'll find you want to talk to the vendor to get you the QC today, and they'll tell you we have ordered, it will take 6 weeks. That will really mess you big time because you need QC consistently. Even if you will be laying back to your alternative QCs, you really need supply of stocks consistently. So manage your reagents, make sure they are at the right temperatures, monitor the temperature even in your room where they are being kept. Just make sure that you have appropriate guidelines per the manufacturer. I've said best practice in terms of reagents. Do random checks. Just make sure that you have adequate stock with you. And don't over order because again, having expiries on you will not really be a good thing. Your employer will start asking you where this money is going. FIFO, we mean what has come in fast needs to go out fast. But again, as I said last time, once you get, let's say, a lot that is expiring in a week's time, you don't start using the one that came fast just because it came fast. So you use the one that is expiring fast. So you need to ensure that. And when you have automated systems, I've said it's very, very good, very easy to use because when you have a software, it will even tell you which reagent is expiring. I'm not telling you to go automation. When we are a big institution like we are, we need the automation. If you are a small lab, don't insist. Don't say, we learned from the webinar that we must have automation. No, we cannot force institutions to implement automation. But if you are able to automate, please go automation way. It isn't your work, it brings in efficiency and all that. So before you even go further, you need to make sure that your staffs are trained properly on reagent handling, on that software. If you have it, make sure that you train your personnel, they understand, and even make sure that you have sign-offs because when people have signed and they take responsibility, they know that they take, if they are asked, we did it. Were you trained? Yes. No, I was not trained. No, but there's evidence here that you are trained. So maybe you just need a refresher. So audits, you need to do it for your IQC, for your quality management system. When you audit, when you review, and sometimes some people will tell you they're bench audits. When you look at them, what is happening on the ground, you will really understand exactly if people are complying or people are not complying. One, with the protocols, that is the SOPs. And two, you'll also identify areas and check for points of improvement. As I told you, please don't be punitive. But again, I'm not saying that people who are careless and they're making errors intentionally should not take responsibility. People should take responsibility when they are careless, when they are like, all that, because there are patients in the line. When you're auditing the process, I've just put there some of the few things, but again, use your standard. Use your standard if you're accredited. If you're not accredited, just the policies that you put in place, check for compliance. So you'll look at the whole quality assurance. And when I say quality assurance, it's the process, not the QC. It is the process that you have put in place. You look at the calibration. I reminded you of the verification of the instrument and also the calibration that is done. Check if this calibration is being done. Confirm that QC is passing. And if it's passing, do you have any bias? Do you have any trends? Look at the standards that you are accredited with. Look at the training and the competency of this staff. Is it there? If you have said in your policies or your protocols that we will do competency once every year, is it happening? And how are you even doing it? Because if you are doing competency, let's say, for example, microbiology stuff, and they are doing cultures. So have you done competency on this stuff? Do they know how to identify some of these growths that have come? I'm just giving an example. So if they are telling us that they have identified strep, and in real sense, they have identified something else, a fastidious organism or something like that, I want you to remember that competency of staff will really impact. If I have told the doctor that this is the antibiotic that is sensitive to this bacteria, they need to give that antibiotic. If I'm not competent enough and I'm trying to guess my things on that table, it really impacts on patient management, like seriously. So that is the example I'm giving. So also ensure, audit your inventory. Check, are they doing the right thing? Are they doing lot to lot? Because when a reagent comes in, I have told you, like, let's say, for example, Biorad came in with a reagent, for example, that was kept under room temperature and it was supposed to be at cold temperature. I'm using Biorad because we're doing a presentation on Biorad. So if this came in with wrong temperature, you know it will not perform optimally. So you have to do lot to lot. Verify that this reagent is working optimally. So did you do that? Did they do that? You as the person who is auditing, did you do that? Did they comply at that particular point? When we talk about risk management and error reduction, this is very important, but apparently we are a bit lucky because we are favored, let me say we are blessed, that we have a whole department that supports us on risk management. But look at the risks. Look at if this lab has identified some of the risks that may be there, identify the risks and even mitigate them. Come up with controls that they will do and mitigate them. You don't need to mitigate risks 100%, but you need to show that there's something you are doing about the risks that you have seen. For instance, if you have a lab and you have to look at the risks that will happen in pre-analytic, analytic, and post-analytic, you don't need to identify all the risks, but at least you need to identify some of the risks you can see. Maybe you have put an entrance that looks like it may fall on a patient. So you need to, I'm just giving an example, you need to look at that risk and see how you can mitigate it. And once it's mitigated, then the residual risk will come down after mitigation. If it's not coming down, you need to review that risk again. Again, the principle is all your medium and your high risks need to be reviewed. You look at them regularly, and by regularly, maybe you have defined in your policy how regular you'll be looking at your risks. The topic of risk management is a whole topic altogether, so we cannot even exploit in this discussion. So I have talked about getting feedback from your clients, and I would ask, who are your clients? So who are your clients? For your clients, maybe your physicians, your clients may be your patients, your clients may be your nurses, your clients may be even this local community around you, because when you're things like disposing waste, you really want to take care of your environment, that community may be your clients. So when you talk about your clients, it is all the whole lot. So feedback, if your community says you're discarding waste in our backyard, please listen to that and look at it. And this strictly, I'll talk about QC, because when you have seen your QC has failed and you're looking at what the problem is, please define it. What happened? When did it happen? Is it in hematology, biochemistry? What really exactly happened? And when we say who, we are not looking at being punitive on that stuff. When we say who, we just want objectively to see if this who is trained, if this who is competent, if this who, and sometimes if you're very objective, you'll find that who really sometimes did not make an error. It's the leadership that did not train that person. They didn't give them even the competency So again, that's why I said we need to be very, very objective. Do immediate corrective action, investigate the problem, and then come up with preventive action. Why I say preventive action? Because when you come up with a root cause and the problem is not correcting, then please go back to the drawing board, do again brainstorming, see if the root cause that you came up with, it's okay. It may be the problem. Maybe you are just trying to give excuses. Be very objective. And the best way to do this, from my experience now, is that let the staff say the truth, and the truth will set them free. It's like telling a lawyer what you did, and then they go defend you the way they know how. So let them say the truth, because from the truth you'll know. They'll tell you, I was fatigued, I was very tired, I was doing a night shift, I got asleep. Then you'll start thinking, if staff is maybe working longer hours, can we reduce the hours to, instead of 10 hours, we reduce to 8 hours? All those are just examples. Let them say the truth, and you'll always come up with the right root cause. What are some of the practical steps of implementing these quality practices? Look at what you have currently. You may not be Aga Khan, you may be yourself. So look at what you have currently. Do a risk management. Look at your risks. What is in that QC that you may come up with a risk, like a risk in that whatever. Sometimes you may not even see the risk, but think about it. What are some of the risks that you may find in terms of quality management? So develop a policy to come up with SOPs and the procedures of how you should manage some of the QCs that you have. Then do a regular training and do a competency. For our standards, we say when a staff is employed, I will do a competency after a training, then I will do a competency after 6 months. After the 6 months, I will do another one after 1 year. Then after that 1 year, every year, I'll be doing competency. But in the event there are issues of competency again in between, we are not cast on stones. We may redo a competency for the staff. When you do a competency, there are many ways of doing a competency. You can do a written exam. You can just tell a staff to do something, then you observe, direct observation. So all those are tools that you can use for competency assessment. So you'll do continuous monitoring and then get your feedback loops. I have put this one here because in some cases it works. Foster quality-oriented culture reward. For instance, if someone has done something good, please compliment them. And sometimes it's as simple as telling the team, telling the world that so-and-so has done a good job. So we compliment that person. Sometimes we may go as far as just rewarding that person, give them a gift, something like that. If there's a budget for that again. So do effective communication, have meetings, sit. If you have a corrective action or preventive action to do, make sure that you have meetings, sit, discuss them. Because you may have a problem with one staff, then you find it is a common problem. But if you don't sit in meetings and discuss some of these things, you may not know. People will learn when you talk to them. And I think meetings is one of the things you can do. Instead of giving people memos, they may not understand what you're trying to say, writing them emails, they don't understand what you have told them in that email. So hold meetings and discuss things. Listen to them. Don't behave like you're the only one who knows everything. Just listen. They may give you a point that may really also make you, oh yeah, if you mean that, maybe that is what we should do. And some people also know, not just necessarily you. I want to welcome any questions. I think I've finished my presentation, and thank you for listening to me. I know it has been a long one, but I hope it has been very productive. Thank you.
Thank you, Jackie, for the wonderful presentation and for shedding light on maintaining a good quality management systems when it comes from also pre-analytics, analytics, and also post-analytics. So we're going to go into our Q&A session. In case you have any questions, please write them on the chat or raise your hand. So we're going to start with some comments. We have a comment from our friend Vincent Utava. He says, this is a good presentation. All labs ought to implement all relevant QC protocols are defined in the relevant standards. And then a TMV, that is test method of validation or verification, is key for all testing platforms. Then we have a question when it comes to, are we going to provide CPD points? So our team will be in touch with you once we align on that. Then, Jackie, there are numerous requests if we can share the link to your presentation. Please advise.
As I did last time, I think I'm not mean, and knowledge is good when it's shared so that I don't become a swamp. Yes, I will share a PDF presentation to all members. If you are able to access this, if you're able to share this with them, then I don't have an issue. What my question is are you able to get all members that attended the webinar?
Yes, we have a log of that. So kindly share it with us. Then we're going to, as we are sending feedback, we're going to include it in the feedback form.
Okay.
Yes. So we have a question from MP Sharp. So he said, afternoon, Jackie, please state some of the reasons for systematic issue and how to go around in terms of mitigating it.
So someone is asking if some of the reasons why we should have systematic failures of IQC.
Yes.
So and you said that is MPSHA, or you named the name?
The name is MPSHA. I think it's the stuff from MPSHA.
Okay. So yes, and again, there are many. Like seriously, there are so many. And once you work with them, you'll see what are some of the reasons why QC should have systematic failures. But I just mentioned few. I said that if your equipment has not been performing optimally, remember when you have done your verification, there is something else called preventive maintenance. We call it PPM, planned preventive maintenance. If this equipment is not maintained well, leave alone even the planned preventive maintenance, if, for example, you are supposed to be calibrating every time of testing, I know that with that calibration failure or distortion of the calibration curve, it will give you a systematic problem until you act on it. It will show you you're going up, up, or you're going down, down, down until you have a failure. Another way is if you've not done your PPM, like for instance, it's supposed to be done twice a year, you're doing it once a year, you'll find yourself having systematic issues, like the QC is either going flat or so even failing consistently. So again, there are very many issues that you may look at. Most of them we will tie it to the instrument. Some of them we may also tie it to the staff competency, because if it's the same staff running it and they don't know how to do it, how can you, what do you imagine? What you imagine is this will be a consistent problem that is failing. So if you have a lab that you have different staff, that's why you don't keep one staff on one area for long. Let them change so that you're able to see if there are any errors you're able to pick. If Jackie did not do this, how come this one did this? So you find out issues of incompetency, all those issues. There are very many as you can pick them. I hope it has helped.
Okay, thank you for the feedback. We have another question from Monica Gidai. She asked, kindly clarify on how to manage numerous point of care equipment in terms of IQC and EQA.
So point of care, and as I mentioned before, I have been privileged to give a presentation and a training in terms of point of care by let me get the name of this thing. Yeah, so by this GWP, that is global health, and also Department of Health, Social Care, Royal College. So I will be giving that presentation. I've already done it. So very soon, I hope you guys look out for the same, because it's not just me. It is also our POCT chair who will be presenting in the same. Our manager will be presenting on how to manage POCT. Our POCT coordinator will also be talking about the same. So when it comes out, because this is a global thing, I wish that you also join to see some of the things that we have put in place. It's a webinar. And the many equipments, again, let's say, for example, you are at Aga Khan Hospital. The many equipments, and believe me, when you're dealing with clinical team, there are nurses, there are doctors, there are assistants who are working on that equipment. You cannot survive with manual processes. So what we have done is that we have automated the system. So when you are doing IQC, you have to have a lockout system. If the IQC has not passed, then they cannot proceed with patient testing. Otherwise, you'll be very depressed trying to run glucometer 1, glucometer 2, and there are over 60 glucometers around. There are over like 10 blood gas equipments. So you need to have a system, let's say, invest in automation, so that if I am seated in my office, like right now, I'm able to log in and see IQC failed, so they did not run anything. If there's any troubleshooting, personally, I can go in and just do troubleshooting. So that is the way to go. Otherwise, you'll be very depressed, because you can't run ICU, medical ward, the children's ward. They have not done the right thing. That is the way to handle it. In terms of EQA, in terms of proficiency testing, because we need to run things the same way we run our patients, we will have a schedule. We will allocate, for example, I have put in January, we are receiving EQA. Jackie will run it because she's in ICU. Because it may come quarterly or after monthly, I'll also allocate, let's say, Leah to run a certain EQA. By the end of time, I need to ensure that these staff who are running our IQC, who are running our patient tests, are rotating. That is all that is required. I think I have answered that question. If not, let me get it again.
Okay. So Monica, please confirm. You can also catch Jackie and the team on their upcoming webinar to understand more on point of care instruments. The other question is from Elizabeth. She says her lab is struggling with unexplained shifts on the Cobas C311 chemistry analyzer. What could be the problem? We have tried changing control material, calibration, but no improvement. How can we go about this?
I didn't get the first part of the question.
They are struggling with unexplained shifts on their Cobas C311 chemistry analyzer. So they have tried changing the control materials, also calibration, but there has been no improvements.
So sometimes when you're doing very many investigations, you really need to be there. I don't know, but I can also just give possibilities of what some of the things that may be happening. So IQC is passing, but they have shifts and trends, if I'm not getting her wrong.
They have shifts.
But it's not like failing.
She has not mentioned that.
Okay, so I want us to look at different things. So when you're doing your IQC, you're looking at your shifts, you're looking at your trends, you're also looking at the overall Levy-Jennings, how they appear. So whenever you look at those shifts and you look at those trends, you need to make a decision. I mentioned before, like when you have verified your QC, you have your, I don't know if I mentioned that, you have your internal limits. And I also mentioned that sometimes what the manufacturer has said does not really happen for us, especially in Africa. And that's why QC verification is very important. So if you find that your QC is misbehaving so much, And when she or he's, I can't remember if it was a he or a she, if they talk in terms of Roche, I don't know what specific analyte they're dealing with. But I want to say, for coagulation, for example, what we have done is we get manufacturer values and you find you're struggling. The accreditation standards require that, yes, you can adopt your in-house mean. What you do is you get all the runs that you have been doing all around that time, like let's say in a month, review it, see what is your current mean. I showed you guys how to get your mean. Try using your in-house mean that is not the manufacturer mean. See how it behaves. It may change the issue of shifts and trends for your equipment. I have finished.
She's also asked if there's an issue if all control points are on the mean.
No, I don't think there's an issue if all of them, because when you look at hematology analyzers, most of the time, unless the equipment has a problem, most of the analytes will be at the mean. I don't think that's a problem. It's like asking, if I'm perfect, do I have a problem?
Okay. So we have a question from Mr. Kevin, quite specific to an instrument. It says, I have a concern on the point of care fine care amino acids. It has a QC chip, which is run every time before you run the test. How is the validity of these control chips?
I don't want to refuse on the viability. Control chips are good. Some calibrations, they'll give you a chip and you calibrate using that chip. There are others who will give you QC as a chip, but for good laboratory practice, you sit down and ask yourself, do I really want to verify this chip or I just want to continue with this chip? Again, what we normally do, where I was mentioning something that people call external quality control, where they are getting another quality control to just verify this one. So if a manufacturer has given you a chip, that is what the manufacturer used and validated for that equipment. So I really don't think it is not viable just because it's a chip. I have not encountered a chip as a control, but I have encountered a chip as a calibration tool.
Yeah. So I think Kevin, you can set that up with the manufacturer for that equipment. This is, I think, a further comment.
Just to correct you again, what I meant with that is that if I have a chip and I feel I want to verify the validity of this chip, I will do something extra. But I'm not saying it's not viable or it's not valid.
Okay.
Yeah.
So I think this other one is on the IQC for point of care. Are you able to send us a link to the webinar that is upcoming? We can share it with the people who are interested, so they can get more information on that.
So because this is in progress and they have not rolled out, I don't want to spoil for them. After it is out, because you guys, we know each other, I can send the link to send to your customers so that they can join. There'll also be an exam for that effect. So someone needs to pass for you to be certified that you have gone through a point of care testing course.
Okay, well noted. We have a question from Mr. Mustafa. He's asking, what are the risks associated with using small sample size?
The risks associated with using a small sample size?
Small sample, yes.
In terms of IQC or in terms of validation or verification? If Mustafa is here, he can just clarify that so that we can go together.
Mustafa, are you around? Mustafa, in terms of QC. Okay. Mustafa, you have access to the mic. He's saying QC in the comment section.
Maybe let me just assume he's talking about verification. Can I assume that?
Mustafa?
Can I assume that? So let me just assume that's what he meant. But I will answer him in a very like broad way. What I know is that data, you need big data, good data for you to have a statistical interpretation or sense. So what happens is that when you have a small data, your statistical interpretation will be skewed. And when I mean skewed, it means it may be biased. For example, if I have, I'm supposed to use 20, I'm using 5. You see, it's just based on those 5. So I've not looked at the bigger picture of that statistic. So it will be skewed. It may give me negative, but it's supposed to be like seriously be either positive or something like that. The risk is we'll skew our data. It will have either negative interpretation in terms of statistics.
Okay. I hope that's clear, Mustafa. On to the next question. The question is, what affects the calibration curve?
Come again?
What affects the calibration curve?
There are many things that are going to affect your calibration curve. It can be maybe the material that you used as a calibrator. I mentioned that when you're having your reagents, verify that they're even kept in the right temperatures as the manufacturer has advised. How it was analyzed, again, calibration curve does not just come in. It was something that was tested, then it became a calibration, and then we got a curve. And you do more than 1 point, 2 points, or something like that. So you may have all those factors together, then you find your curve is not what you expected. So if the material deteriorated, it will give you a curve that is not what is expected of you. That is just one of the examples, or two of the examples, plus many more.
Okay. Next question is from Joe. Please explain how to troubleshoot the 10x violation despite QC passing.
Remember, your 10x violation is like a bias, right? So how you will troubleshoot your bias is the same way. This is a systematic problem. Remember, when you get to your 10x, meaning you are not looking at your QC anymore. So you are supposed to look at it even before it reaches to 10x. So when you review, because again, the requirement is whenever you analyze your QC, you need to see, you check how it is behaving. By the time it's reaching 10x, there was an issue already. So if it's a QC material that, for example, you are using a QC, maybe you thought, then you're using the same one, just ensure that you change your QC material. If you look at, there are very many things that sometimes you'll, if in case, let's say you are the person in charge of IQC or QC in your department, you need to help staff by putting some of those items that they should be looking at when they're reviewing their IQC. So your IQC, by the time it's reaching 10x violation, there was a 1, there was a 2, there was a 3, there was a 4, and up to 10. So look at it even before it reaches at 10x. Basically, that's what I will advise. And I want to say calibration can also be another issue. Look at your calibrations. How is your calibration working? Basically, chemistry analyzers, when you look at them, and if it's not calibrated, basically you'll see either a violation, something, calibration failed, stability of your calibrator, something like that. So always review your curves, review your LJs, before it reaches to your 10x violation. I don't know if I have answered that question correctly or if they have understood what I've said.
Joe, was that answered satisfactory?
Do you what?
I was asking the sender of the question if they have understood the feedback. In case they have another question, please write it down there. The other is coming from Lawrence. He's asking if you can elaborate between sensitivity and specificity.
So just someone is reminding me here that when you have reagents, for instance, remember when I talked about managing your reagents and reagent inventory, we get reagents and we put them on the equipment. So once you put your reagents on the equipment, there's that expiry that the manufacturer has told you. And there's this expiry that is called on-board expiry. There are people who will put their reagents on board and they'll never check whether they're expired or not. Manufacturer has said, for instance, if you have put your potassium reagent on board, let it not stay there for more than, for example, 5 days. If you keep it there for more than 5 days, believe me, you will have your controls misbehaving. And as I said, we are blessed differently. There are people who will argue, how do I throw away my reagent? Remember, when you're putting on board, make sure that you put what is sufficient, what is enough. Once it's consumed or used, you pick another one and put. Because on board expiry also messes our curves, messes our everything that we do in terms of quality.
I think that is the last of our questions. So thank you, Jackie. I'll now hand it over to Leah for any closing remarks and next steps.
So I think there's one that you had asked about sensitivity and specificity.
Oh, yes, please.
As we had mentioned in my presentation there, remember when you're talking in terms of sensitivity and specificity, simple things, this is sensitive, this other one is specific. So in terms of quality, we will define it as maybe as a method being able to identify a positive disease. And when you're talking in terms of specificity, when I have a negative of a disease, it should be able to give me a negative of a disease. Now, when we are doing statistical analysis of specificity and sensitivity, remember there are things we used to learn about predictive value, negative, positive predictive value. All that is things that you can come through to just check how positive is this, true positive is this sample, that we call it sensitivity. How true negative is this of this method, that we call it specificity. So there's more to it. There's more to it that you can look at, talking in terms of the predictive value, positive agreement, negative agreement, all that when you're talking in terms of specificity and sensitivity. But again, as I said, we are in this one space. I know we will meet to define more things in terms of risk, in terms of uncertainty of measurements, in terms of sensitivity, in terms of specificity. So there is a formula for the same, and feel free. You can even Google that formula. It's all over. Over to you.
Thank you so much, Jackie, for the wonderful presentation. We have reminded ourselves so much. I'm sure others have even learned something new from you. So thank you so much. And we hope to see you again and again. So we have a next webinar in end of October, probably. So we are still planning. So like we said in the first webinar, for those who are joining for the first time, we'll be having series of these QCs now and then. So we held our first in July. So this is continuation of the first one. And the reason why we did this is because some people are saying that they need to know more about QC in deep. Because last time we had 3 speakers And we changed the plan so we can have a speaker at a time, so we can have enough time to go deeper into the QC practices in our labs. So now that you have understood about the QC overview and all the key management concepts, so the next one will be about the regulation, which is ISO 15189, the current one, which is 2022. So we look at the requirements, what are we needed to do in terms of QC and also risk management. So this webinar will be done by one of our assessors in Kenas, with Arnold Nyaga. I'm sure some of you or most of you know him. So let's meet in October. But before then, we'll have a QC webinar again from Biorad in 19th September at around 2 p.m. So details will follow. So you again receive our communication to you. Kindly join. So we say that we not only sell to you these QC products, we want to ensure that the QC that you are using in your lab, you are able to use them in a manner whereby you are able to know what's happening in the lab. Be it the QA managers, be it the lab managers, be it the technologists, we all want to ensure that you are not just running the QC. We want to understand why are we doing the QCs, what is required of us by our accreditation bodies, so we are able to know more about it. So we still have this, and I hope that this will bring impact into our laboratories. So I will close at that. Unless you have any more comments or questions, thank you so much. And Jack, just to tell you that we are not only educating the Kenyan team, we also have Uganda people in these webinars. So you are preaching even outside the borders. Yeah. Thank you so much, everyone. See you next time. Yes, sorry, Jackie.
I was saying we are blessed. I think now we are concentrating on these things because in the POCT one, we'll be preaching to even the US and the UK people. So yes, this knowledge is not for you to sit on it. We will share as much as possible. Feel free to get through us, maybe through Biorat, because they can always get us. And whatever question you forgot or you want to ask, we can always answer offline, even post this webinar.
Thank you so much, Jackie. Thank you so much. So we wish to end at that. Just to mention, we have Fiona online. She says hi. For those who, some know her, others don't. She's from Biorad. So she says hi, and hoping to see her on 19th September this month. So thank you, everyone, and enjoy the rest of the day. See you next time. Bye. Bye-bye.
Thank you.